Slide 1. This lecture is the third of a series which relates to the lower limb. In this lecture, you're given an overview of the function of the knee joint before considering the articular structures in more detail. Again, it will be useful to have a textbook to hand, as there are some questions along the way. Probably not much fun, but they help avoiding sleep. Slide 2. Following this lecture, and with your own further reading, you should be able to describe the key functions of the knee joint. You should be able to describe key bony points and be able to explain the relationship between the structure and function of the knee joint. Slide 3. The knee region is that part which includes the distal end of the femur, the superior end of the tibia and fibula, and the patella. It also includes the Popliteus Muscle, which is a hollow area at the posterior aspect of the knee. So, what do you think the main functions of the knee joints are? Slide 4. The knee enables many body functions. It can act as a stable column, for example, when the knee is extended in standing. This is a critical position for weight bearing, without the requirement for significant muscle work to maintain this posture. When the knee is flexed, it enables an individual to walk, run, kneel, squat, jump, crawl, lunge, climb. The knees, to some respect, have to mimic the role of the hips, being both stable and strong, but also they need to allow a relatively wide range of motion, if the person is going to be able to do activities as described before. However, it's notable that the knee joints primarily move in the sagittal plane, in contrast to the hips, which can move in all three planes of motion. Slide 5. Considering the actual shape and alignment of the bones which are involved in the knee joint, have a look at the bone ends in the X-ray. It's clear that they prove to be very unstable without significant support from other connective tissues, for example, ligaments, tendons, menisci, as well as contractile tissues. These will be considered in detail later. The key point, the bones are relatively incongruent. And note here, the closed packed position for the knee is full extension. Slide 6. Again, time for some revision. Do you know all of these points on the femur? This was covered in the last lecture. Pause here and do a bit of revision if you feel you need to. Slide 7. Can you try and match these bony points to the appropriate place on the tibia and fibula? What attaches to the anterior and posterior intercondylar eminences? The answer, the menisci. More about those later. Slide 8. Here are the key bony points which you should know. Slide 9. A few points about the patella. This is the largest sesamoid bone in the body, and it lies within the tendon of rectus femoris and vastus intermedius. The apex is that part which is most inferior, and the base is that part which is superior. The articular cartilage that covers the medial and lateral facets is likely to be the thickest in the body. The patella can be easily palpated. There is a convex anterior surface and an articular posterior surface. This is smooth and covered with thick articular cartilage. This posterior surface is divided by a vertical ridge, making it a large lateral area and a smaller medial area. There are further ridges that subdivide these areas. There are 7 facets for articulation in total. The patella is important in assisting the quadriceps tendon to lie more anteriorly relative to the knee joint axis. It changes the angle of pull. It helps increase the lever arm of this muscle, giving it a greater mechanical advantage. Slide 10. As the knee moves from flexion to extension, the facets of the patella contact the femur from the superior to the inferiorly lying facets. In the flexed posture, the contact area between patella and femoral condyles broadens, This assists in distributing the increased stress associated with flexion. During the movement of the femur, the patella is held in place by its containment within rectus femoris and vastus intermedius tendon and continuation of the patella tendon. In addition to this, it's supported by the bony groove within which it lies on the distal end of the femur. There are also fibrous connections between the patella to the menisci and the knee joint capsule. As you can imagine, in flexion the patella is held firmly against the femur as the tension increases within the quadriceps. But in extension, there's less tension. Oh, that rhymes. In extension, for some individuals who have a relatively small lateral lip of the femoral surface and or weakness of vastus medialis, may be at risk of lateral dislocation or subluxation of patella. These are individuals we can see for rehab in physiotherapy clinics. Slide 11. Looking at the bony knee joint, can you identify which components form the articular surfaces? How is the knee classified? What kind of joint is it? How many planes of movement can this joint move in? What are the names given for types of motion available in the knee joint? Relatively simple question. Note down the answers now. Slide 12. The knee is the largest synovial joint in the body and is classified as a modified hinge joint. It allows both flexion and extension and some medial and lateral rotation when it is in flexed posture. It cannot rotate when it's in full extension, the closed pack position, so it can move in two planes of motion. The articular surfaces. They are the medial and lateral femoral components, the medial and lateral femoral condyles, and these articulate with the medial and lateral tibial condyles. These are known as the femoral tibial articulations. The femoral patellar articulation is between the posterior aspect of the patella and the femoral condyles. All of these articulations are within the same joint capsule, so note the fibula is not part of the knee joint. As I said before, although the bony arrangement is unstable, the soft tissue structures give it stability. That is, stability from ligaments, intra-articular and extra-articular, muscles, capsule, strong tendons and muscles, and fascia. Slide 13. The menisci are intra-articular, C-shaped fibrocartilaginous discs. They have 5 rows associated with them. These are: they increase the congruence between the tibia and the femur. They improve shock absorption. They aid lubrication of the knee joint. They assist in generating the rotation mechanism of the knee, more about that later, and they participate in weight bearing across the joint. The menisci are anchored at the intercondylar tibia area. As you can see from the diagram, the medial meniscus is larger and C-shaped. This cartilage is the least mobile of the two, due to its attachment to the joint capsule and the tibial collateral ligament. In contrast, the smaller circular lateral meniscus is more mobile. It does still have attachment to capsular fibres via the coronary ligaments, which connect it to the tibia, but it is not attached to the fibular collateral ligament. Note that the transverse ligament connects the two cartilages anteriorly. Slide 14. The picture on the left of an actual knee joint exposing the superior aspect of the tibia with menisci exposed illustrates the difference in shape between the medial and lateral cartilages. Can you also identify in this picture the head of the fibula, which is on the side of the lateral meniscus? In this image, you can also see that they've marked the position of the attachments of the ACL and the PCL. They're circled in black. The arthroscopic image on the right shows what the orthopaedic surgeon would see when they inspect a degenerate meniscus. Degeneration of the meniscus may accompany the changes associated with osteoarthritis. Tears of the menisci are relatively common and are normally associated with rotation of a flexed knee under load. The medial meniscus is the one that's more commonly torn, about 5 to 7 times more commonly torn than lateral menisci. When tears occur in the central region, they often have to be surgically repaired, as the menisci are relatively avascular, with the exception of the outer one-third of the structure. Can you work out what other structures may be injured if a patient presents with a medial meniscal tear? Think of the other things it's attached to. This is how your anatomy knowledge can assist you with physical examination of a patient and your clinical reasoning around diagnosis and management. Slide 15. The knee surrounded by muscle tendons and expansions. Just take a bit of time to look over the diagrams here and just look at how the knee is surrounded by tendinous and ligamentous support on all aspects. There is no entirely independent fibrous capsule linking the femur and tibia. There are only occasional true capsular fibres. The knee joint capsule is like a sleeve with a part missing anteriorly where the patella is situated. The capsule itself is relatively thin, but the ligamentous thickenings are prolific. Within the fibrous capsule is an extensive and complex synovial membrane. The membrane attaches to the edges of the patella and the menisci, and it also has infoldings, enabling it to wrap around the cruciate ligaments and the infrapatellar fat pad. So, take note, these structures are not actually within the synovial cavity, but they are intracapsular. The knee joint cavity actually extends up under vastus intermedius, known as Suprapatellar Bursa. This is very evident if you've ever seen anyone with a very swollen knee. In this situation, you see that the circumference of the knee is much enlarged, well above the level of the base of the patella. This Suprapatellar Bursa extends approximately 6 centimeters above the patella. So, strengthening the capsule, there are 5 extra capsular ligaments. The patellar ligament, fibular collateral ligament, tibial collateral ligament, the oblique popliteal ligament, and the arcuate popliteal ligament. Just stop for a moment and have a look at the position of each in the diagram. Try to work out what aspect of the joint they stabilise and what movements or forces you would have to apply to stress the ligament. Note down your answers. I've put the answers on the very last slide. Slide 16. The patellar ligament is the most distal part of the quadriceps tendon, and it extends from the apex of the patella to the tibial tuberosity. The oblique popliteal ligament is an expansion of semimembranosus. It attaches distally to the posterior aspect of the medial tibial condyle and passes superiorly to attach to the posterior aspect of the joint capsule and attaches at the intercondylar line of the femur. The arcuate popliteal ligament provides posterior-lateral joint support, and it inserts at the posterior aspect of the head of the fibula. It lies over popliteus and moves to the posterior aspect of the tibia and the posterior aspect of the lateral femoral condyle. Slide 17. The cruciate ligaments are intracapsular. They cross over within the knee joint, and that's where the name comes from. Cruciate, cross. These ligaments limit the range of motion of medial rotation as they twist around each other during this movement. These ligaments are orientated to enable there to be some degree of tension within one or both ligaments at every single knee position. They are very important stabilizers of the knee. The anterior cruciate ligament, or ACL, resists anterior displacement of the tibia on the femur, or vice versa. It limits knee hyperextension and medial rotation. It's notable that it's weaker than the PCL. It's injured more than the PCL. The ACL inserts on the anterior aspect, the intercondylar aspect of the tibia, and travels to the posterior part of the medial side of the lateral condyle of the femur. The PCL, posterior cruciate ligament, resists posterior displacement of the tibia on the femur and vice versa, and limits medial rotation and hyperflexion. It inserts on the posterior intercondylar area on the tibia and passes upwards to the anterior part of the lateral surface of the medial condyle of the femur. Take time to look at the insertion points. Slide 18. The medial collateral ligament is strong and flat and extends from the medial femoral epicondyle to the medial condyle of the tibia and the medial side of the tibial shaft. Remember, there are some deep fibres attached to the medial meniscus. So this ligament extends down past the level of the tibial tuberosity. It's approximately 8 to 9 centimetres long. The lateral collateral ligament, or the fibular ligament, is like a rounded cord of approximately 5 centimetres length. It passes from the lateral femoral epicondyle to the lateral surface of the head of the fibula, and it actually divides the tendon of biceps femoris. Slide 19. There are many bursae associated with the knee. Look at the diagram. Can you remember what a bursa is, or what it does? Palestanga et al. 2006 described them as sac-like dilatations. These friction-reducing structures can connect to nearby joint cavities, or they can exist in isolation from joints. They have a synovial-like fluid within them. Key bursa to note around the knee are the large Suprapatellar Bursa, the Prepatellar Bursa. If this one becomes painful and inflamed, it's commonly called housemaid's knee, or more correctly, Prepatellar Bursitis. There is an Infrapatellar Bursa, both superficial and deep, and there's a medially lying Anterior Bursa, which separates the tendons of sartorius, gracilis, and semitendinosus from the medial collateral ligament. Slide 20. Here is a woman who presented to the physiotherapy orthopedic specialist with a painful and swollen knee. The diagnosis was prepatellar bursitis. You should be able to see the swelling on the anterior aspect of her left knee. The fluid which had collected within the bursa was aspirated at the clinic by the physiotherapist. The syringes on the left show how much was aspirated. Go back to the previous slide and have a look at the location of this bursa and see how it relates to the position of the swelling shown here. These photographs shouldn't be reproduced for any other presentation without permission of G-sign. Slide 21. The primary movement of the knee is flexion and extension in the sagittal plane. The knee can also rotate when it is in some degree of flexion. When the knee is extended with the foot on the floor, there is a natural, automatic, or conjunct rotation of the femur relative to the tibia. The femur medially rotates upon the tibia as it nears full extension. This passive locking of the knee enables the knee to form a relatively stable weight-bearing limb. When the knee is locked, it is also in the closed pack position, so there's maximum stability, and the majority of the ligaments of the knee are tense. This conjunct or automatic rotation is linked to several factors. These are described by Palestanga et al. 2008. The first factor, the profile of the distal articular ends of the femur, with the lateral articular condyles being longer than the medial, facilitates this rotation. The shape of the tibial condyles influence this rotation, as there is relatively good containment of the medial, tibial and femoral components. It leaves the lateral femoral condyle freer to slide around. The medial collateral ligament becomes tense before the lateral, and it enhances the rotation. Last but not least, tension within the ACL also produces this medial rotation of the femur on the tibia. Note that if the tibia is the portion that moves freely, for example, the foot is not in contact with the floor, the rotation movements are opposite. The tibia rotates around the femur. The popliteus muscle is vital in its role of unlocking the knee by initiating lateral femoral rotation relative to the tibia. Gracilis sartorius and semimembranosus also assist. So again, like the hip, the active range of motion of the knee is influenced by two joint muscles. So for example, the range of active knee extension is influenced by hip flexion. If the hamstrings are put on stretch by having the hip in full flexion, most people cannot actively fully extend their knee. A similar phenomenon is found in relation to quadriceps femoris. Active knee rotation is approximately 30 degrees medial and 40 degrees lateral. Different texts may say different things. It also depends whether the movement is active or passive. Have a look at the next slide. Slide 22. This shows range of motion being tested actively and passively for rotation at the knee. Slide 23. At the end of this presentation, you should be able to relate the key functions of the knee joints to their basic structure. You should have an overview of the nature of the knee joint, the movements available, and know the bony features of the femur, patella and tibia, which will be essential when you get to grips to muscles in this area. In summary, the knee joint is structurally developed to enable weight bearing, weight transfer and locomotion. Although the bony structure of the knee affords little stability on its own, the interrelations between the ligaments, intra-articular structures and the locking mechanism, or this conjunct rotation, enables significant stability in the extended position. Slide 24. The books used to support this lecture are Gunn, Bones and Joints, a Guide for Students, Moore and Auger, Essential Clinical Anatomy, Moore and Daly, Clinically Orientated Anatomy, and Palestanga et al., Anatomy and Human Movement, Structure and Function. Slide 25. The web material access to support this lecture came from Wikimedia Commons site, the Evolve website, some of my own holiday snaps, clinical photographs from St John's Hospital, and Primal Pictures. Slide 26. So, here are the answers to the slide 15 questions. The strong patellar ligament protects and supports the anterior aspect of the knee joint, and it would be stressed by a stretch to quadriceps femoris muscles. Note that the fused tendons of the quadriceps also support the knee anteriorly, superior to the base. There are also retinacular or fibrous expansions which run from vastus medialis and vastus lateralis, blending with the deep fascia of the knee, helping to stabilise and support the patella and this anterior aspect of the knee. The fused tendons of quadriceps support the capsule anterior-medial, anterior-lateral, as I've mentioned already. Fibular collateral ligament, or as it's also known as the lateral collateral ligament, sited in the lateral aspect of the knee, will of course stabilise that aspect. It can be stressed when a varus force is applied to the knee or pressure is applied to the ankle, pressing inwards as if you were trying to adduct the knee joint. This tension would also be increased with extension. The collateral ligaments tighten with extension. It's the opposite for the medial collateral ligament on the medial side of the knee. Again, it supports the medial side of the knee. It's taught in extension as opposed to flexion. You could stress this by placing a lateral directed force to the ankle as if you were trying to abduct the knee joint. The oblique popliteal ligament strengthens the posterior aspect of the capsule, so it would be stressed by knee hyperextension. The arcuate popliteal ligament is located at the posterior lateral corner of the knee. It would be stressed by extension and adduction of the tibia on the femur. Of course, this adduction force would have to be applied by the therapist, but it's not a movement the individual can do actively. This is the end of the presentation.